We're here at the CROI in Boston. We're here with Mark Polizzotto, who is from St. Vincent's, Sydney, and also the Kirby Institute. And he's here to talk today about malignancies and how they relate in the world of HIV. And it's an educational program, so I think we're going to be trying to talk about explaining some of the nuances to malignancies today.
Thank you so much for having me. It's great to be here.
Thank you for being here.
So I think the first thing to say about cancer in people with HIV is that it's a challenge that really comes from the successes of HIV treatment. I think when we all think about cancer in HIV, frequently people still think about the very difficult problems we had with cancers like KS, CNS lymphoma in the days before effective antiretroviral treatment. And in some areas those are still very important, but I think what we're seeing now is a different group of malignancies, and that's coming about in part because people are living so much longer and so much better with HIV. And so that's kind of what this slide shows, which is the number of people, this is US data, the number of people who are 60 plus who are living with HIV. And you can see that this has gone from an almost negligible group even 10 or 15 years ago to an increasing proportion of people. And that's really important.
The trend is so even.
It really is impressive, right? And so these people are getting older and they're living longer exposed to HIV. And it's important because, as you see here, that means that people living with HIV are entering the age at which cancer is most common in the general population. That's really something we haven't seen before. But more than 50% of cancers generally occur in people after age 60. And so we're really seeing a shift that I think we're just beginning to understand the importance of as people live longer. And you're beginning to see that already in epidemiological data. This is Meredith Shields' data from the US, but we have very similar data where I work in Australia or in Europe, where we see what were the traditional AIDS-defining cancers, and that includes, as I said, KS, but also some of the aggressive non-Hodgkin lymphomas, CNS lymphoma. You'll see that they continue. They're still important, but what we're seeing is more and more of what are called non-AIDS-defining cancers. That's a broader basket. It includes, for example, Hodgkin lymphoma, which was previously relatively uncommon, lung cancer, anal cancer. All of these diseases are becoming more important. I think if you plot this trend out, this only goes up to 2005. If you plot this trend up, you'll see that shift continuing. And certainly we see that in our own caseload at St. Vincent's and at other big centres.
So doctors today, are they aware, or I should say, a lot of the really good HIV doctors are aware of this trend that's happening. Are there doctors who aren't, and maybe we should become more familiar with this? This would be good for them to pay attention to, because
yeah, absolutely.
Patients maybe are going undiagnosed, they're unaware, there's not the sense of prevalence.
Absolutely right, absolutely. And I think it also poses a challenge for those of us who treat cancer. I'm a cancer doctor by background, because what a lot of institutions have had is a model where one champion who particularly had an interest in lymphoma or KS has taken on the people with HIV and cancer. That was a great model for a long time, and those people have made a tremendous contribution. But now, as we enter a new era of cancer medicine, we're going to need people who can treat HIV and lung cancer, HIV and breast cancer, HIV and all these other cancers. It may be that one person isn't going to be able to be across that whole breadth.
But it'd be a group.
It would be a group, exactly. It may be moving to a model with one, if you like, coordinator who has a broad expertise with HIV and cancer drugs, who brings in specialists in those particular cancers as they go. I think that's one model people are thinking about. And you're right as well. I think that people who are living with HIV, people treating them in the more primary care setting, the primary HIV problems, these shifts are important to know about. And probably some of the approaches to working up someone with a potential cancer, getting them to the diagnosis as quickly as possible to get them onto good treatments, all of that I think is very important.
Because being diagnosed early in cancer is very important.
Absolutely. And I think it's a shift in mentality as well for everyone involved, from the days where, say, presenting with a CNS lymphoma might be a very nearly end-stage event for that person, and often a more palliative approach was appropriate, to recognizing, say, that an early diagnosis, let's say, of lung cancer or Hodgkin lymphoma, while those are serious diagnoses, they can be completely curable if they're diagnosed quickly and treated. And again, that requires awareness right across the spectrum.
Are there places where a person, an individual, a patient, or even doctors could go to determine what are the warning signs and the symptomology for these cancers? Is it?
So that's a great question. I think the US NCI has a great website at cancer.gov that has a lot of patient education, and they include some really good sections on malignancies that are important for people with HIV, including Joel Pilevsky, has a great section both on anal cancer and the precursors to anal cancer. And there's a lot of other good sections there. And the AIDS Malignancy Consortium, again, they have a website that has some good videos, including from a patient and a clinician perspective, a little bit more focused on clinical trials. I think those are both good resources.
Right.
And there's absolutely room, I think, to do more to build that up.
Well, that group per se is going to be doing a program, as I mentioned you earlier before we started the program.
Yeah.
And they do that every year.
work.
But they're talking mostly about the science and about the research that's going down, as though you know everything. So you're here to kind of give us a background and sense of the wrap, so to speak.
Yeah. And I think that is really important. To make sure that we communicate with people at every stage. Yeah, the big picture, absolutely, absolutely.
So yeah, we've been doing this, and I think it's amazing because a lot of these things, there was moments in the CROI where they would say, like I know one moment where they were discussing opportunistic infections, and they said, and then there's osteopenia and osteoporosis. And Dr. Powderly dropped that bomb at the end of the early CROIs, and everyone said, "Oh," and like we really didn't think about it, and then now we're seeing there is that more with women and so forth. So it's something that you progressively see these things materialize and become more prevalent or more obvious as time moves on. So the doctors who are not familiar with this, or the patients who don't understand this, getting more, not that they should become hypochondriacs, but to be aware of things reasonably, so they can go to their doctor and say, could this be cancer?
And I think the key message there is maybe is kind of implied in what you're saying, which is for people living with HIV to maintain that close link with a primary care doctor who knows them well. I think that's crucial, and in a way, as we've become so good at treating HIV, it can become another one in the list of many things that people have to worry about in their lives. That's great. That's fantastic. But maintaining that close primary care link, I think, is an ongoing importance, so that when something unusual happens, whether that's people losing weight, people having fevers, a lump they don't recognize, these sort of things, they have someone who can put that in context for them, work out what the most appropriate investigations are, and do that relatively quickly. I think that's really important.
Right.
And I think you're right. Actually, something you and I were saying before we started, and it's funny that you mentioned osteoporosis, because I had an older woman, an 80-plus woman in my clinic not that long ago, and I suddenly recognized this is a whole area of HIV medicine that I've been dimly aware of, but not had to do in practice. I think that's true for a lot of us as people are doing so well and living so long. The breadth of problems that we have to be across in a way is broadening. I think for all of us as doctors, these sort of sessions are really helpful to catch up as well.
I think someone did say, and I don't know whether this is really true or not, but they said, if you live long enough, you'll get cancer, I think.
I think that is true. It's very much in Western societies a disease of living longer and doing better. Absolutely. Yeah. That said, one thing we should recognise, you and I are talking very much about the situation in US, Europe and Australia, but clearly in places like Africa, even with the fantastic efforts that have been made to ART rollout, clearly they're at a very different point in this sort of curve that we're talking about. Again, the AMC is doing really important work in Africa with diseases like KS and also now lymphoma, looking at treatments that are going to be deliverable in a very different setting to what we're used to. I think that's a huge part of the global challenge, although it's not the challenge that you and I see every day. And cancers there are still, I think, under-recognised and very important.
Right. I wanted to make sure you cover all the material you wanted to cover, because there's so much we could talk about, and it's just a matter of capsulizing and saying what are the things that people really need to know.
So I guess let me do one more summary, and then I might talk a little bit about what I think is interesting that's kind of emerging. And this sort of speaks to what you're talking about, which is what's the big picture. Again, these are mainly American data, and the point here, I think, is to show that even as we're doing so much better treating people with HIV, these malignancies are still at elevated risk. And so the most interesting column maybe is this standardized incidence ratio, which is essentially the comparison of people with HIV to otherwise similar people who don't have HIV. Again, some of these diseases are going to be very familiar, these striking elevations in KS, primary CNS lymphoma. Again, these data are now from the 2000s, and some of those probably reflect an earlier generation of HIV treatment. People maybe are more surprised to see some of these diseases in the not AIDS-defining cancers that we just saw, but I think lung cancer is increasingly recognised as important, more than twice as likely in people with HIV as otherwise. Anal cancer, and we mentioned some of the important work in that. Hodgkin lymphoma is still 5 times as likely in people with HIV. And so that's really the breadth of common cancers and a persistently elevated risk in those cancers. That's not to say someone with HIV can't come along with breast or colorectal, but those risks don't seem to be as elevated compared to the ones on this slide.
They would be the standard risks, so to speak.
Yeah, standard or close to standard risks, absolutely. Again, some of that picture is going to become a little bit clearer, I think, in the 5 or 10 years, because particularly diseases like colorectal, breast, maybe even prostate, skew very much to the over 60s, and so we'll start seeing what that means.
Right, because everybody's going into that now at this
Exactly
point,
right.
yeah.
And so there haven't been a lot of those older people in these big epidemiological studies, and those studies by their nature are kind of, I don't want to say backward looking in the sense that it's not good science, but it takes time for people to show up in those studies. But in the next few years, we'll see a little bit of a clearer picture about what age is, how age is playing
Since
into
cancer is such, and maybe bone disease, we said earlier, those are things which aren't, maybe you will see an end-stage disease show up at some point, become obvious. But people can live with that for a number of years and go undiagnosed. Do you think there's a lot of that out there?
So I like to think that we do a pretty good job of picking up people with cancer. I think the biggest problems in terms of missing cancers are actually missing the HIV diagnosis that I've seen, and I'm sure you'll have people talk about the treatment cascade and the importance of getting on therapy, and we can talk about that.
So you're saying people aren't not diagnosed
people
for
who
HIV?
don't realise they have HIV and present late stage. I think
then they therefore would be more at risk for other diseases.
Absolutely, and certainly we all occasionally, regrettably, see people whose first recognition that they have HIV comes when they present with KS or lymphoma particularly, but also other cancers. I think once people have HIV, as long as they stay linked to care, that we do a relatively good job of diagnosing at least the common cancers. Again, as long as people present, and sometimes you do need to be a bit persistent in presenting with a symptom that's troublesome. So the other striking thing I think about this list is that many of these cancers are themselves caused by infections, and that continues to be the case. Certainly in terms of the AIDS-defining cancers, the overwhelming majority are caused by other cancer-causing viruses. For example, EBV, KSHV, or human herpes virus 8, and HPV, very important for cervical cancer. But even in these non-AIDS defining cancers, clearly anal cancer, again, caused by HPV, just as cervical cancer is. The great majority of cases of Hodgkin's lymphoma are EBV associated in people with HIV. Head and neck and liver cancer each also have viral associations. And so that speaks to the importance, I think, of maintaining a good immune response, and probably also the importance of other factors like inflammation in controlling these viruses, which are very common, and making sure that they don't progress to a malignancy. The thing I think that's really important to remember when we're talking about cancer in people with HIV is to set it in the context of just how much progress we've made in cancer in the general population. Because I think a big part of what we all do, whether it's the AMC or other trial groups, is making sure that people with HIV, once they're diagnosed with cancer, are able to keep up with and receive the benefits of the advances in treatment. So these are data from the NCI's annual report. And to orient you, this is men and women, the most common cancers in those groups. It's about the top 15 or 20 in each case. And this is the percentage change in mortality over the last 10 years. Then the scales here are actually the annual change. And so it's kind of striking. This is since 2001, that for cancers of all types, there's almost a 20% drop in mortality for all cases for men and a 15% for women. And for some of the cancers we're talking about that are particularly important to people with HIV, like non-Hodgkin's lymphoma and lung cancer, you're seeing a 25% drop in mortality over that time, which is really striking. Sometimes, I have to be honest, I show this to HIV doctors and they're used to the kind of advances we made with heart and they're like 25% mortality, you know, go back and work more. But to be honest, for diseases that have been so difficult, this is striking. And some of the new treatments that have come through, including immune modulatory treatments in the last few years, are going to keep pushing this mortality curve even better.
What would you say is the biggest factor to getting that improvement?
So I think in this decade period, it's been advances in therapy.
And maybe early diagnosis.
And potentially earlier diagnosis for some of these diseases. It's going to be a little bit different for every disease on that list, I think. But certainly I think breast is a great example, and colorectal, where early diagnosis and screening programs are probably helping with this. I would say for non-Hodgkin's lymphoma and for lung cancer, it's probably being driven more by advances in treatment in that time. But there's going to be a slightly different story for every cancer. As you say, one of the important messages for people with HIV that comes from this is the importance of seeking medical attention, taking symptoms to their doctor. And I think the importance of it for those of us who work in cancer is to make sure that we're working to make sure that these new treatments are available to people with HIV. For many of these treatments, that means specific studies. If there's a difficult drug interaction with antiretroviral therapy, or they're drugs that act on the immune system that may act differently even in someone with well-controlled HIV. In some cases, that may be that we can just build people with HIV into existing cancer trials as we go forward. Historically, that's been very, very difficult to do.
So it'd be like a nested study or?
Yeah, some sort of stratification so that people with HIV could come on. And certainly for diseases that are very common with people with HIV, like lymphoma and KS, it's been relatively straightforward to do focused trials. That's going to be tougher again as we start talking about even lung cancer, colorectal cancer. It becomes tougher to have dedicated trials in HIV in each of those areas. And there are people like Rich Little at the NCI, run in CROI, who spend a lot of time thinking about how we adapt our trial infrastructure to really address those problems. But we do want to make sure that we have safety data and effectiveness data as far as possible in people with HIV to link them in with this progress. And yeah, as you say, I mean, it's fantastic progress, just as there's been fantastic progress on the HIV side, and it's important to keep sight of that. You're absolutely right.
Great.
The other thing I think, and this maybe comes back to what you were asking me earlier, maybe I should have had this slide earlier, is we're continuing to understand just how important antiretroviral therapy is in reducing the risk of cancer in people with HIV, and I know you'll hear more from Insight and the START investigators today. And later in this meeting, Alvaro Borges, for those investigators, is going to be presenting more detailed data on the START study and cancer. But as you know, this is a study that compared immediate commencement of antiretroviral therapy, which at the time was not standard, with what they call deferred commencement, which is essentially waiting until people's CD4 count dropped below 350 or they got an AIDS-defining malignancy. It's really important to recognise these are still both outcomes. I mean, even you and I certainly remember when we waited way past 350 to start people on ART. I mean, recently, right? So, so I think it's really important to emphasise that both of these groups are actually being treated in historical terms relatively early. Whether it's even though it's called deferred, it's not deferred by
and they're even looking
recent standards.
at the lead controllers as maybe there's something going on, even though they are controlling the virus.
Absolutely.
There's still that undercurrent.
Yeah, I think that's absolutely right.
But KS is something that became obvious, I think, the treatment itself.
Absolutely.
Did what it needed
but
to
you
do.
know, I wouldn't honestly have expected that between a CD4 count of 350 starting treatment and CD4 counts above 500 that you would see this bigger difference in KS.
Yeah,
because
that's
we think of
amazing.
KS at like 50, CD4s of 50, CD4s of 200. This kind of change is really striking.
The START study stopped.
Yeah, they stopped it because the differences were, and so this common point I should say is everything, not just cancers, it's AIDS and non-AIDS defining. And then I've broken out the 3 cancers from the paper, and again, Dr. Borges will present this in more detail, but essentially that's about a 90% reduction in the risk of KS by starting earlier. And you're right, some of that may be about not just the immune system, but things like inflammation that may even be happening in elite controllers. This I think is the really important message is about getting diagnosed and getting on ART, but it's also a real clue for those of us who try to understand the pathogenesis of these cancers to work it out. And again, for malignant lymphomas, which are all grouped here, that's Hodgkin's and non-Hodgkin's, it's about a 70% reduction, or it's small numbers, so it's not quite statistically significant. And then for non-AIDS defining cancers, about a 50% reduction, again, not quite statistically significant. But I think they're important numbers. And this, while the study has stopped, these people are still being
Oh, yeah,
followed.
right.
And the lead time to cancer is probably quite long. So these numbers will continue to evolve.
But the thing is, I think people, human behavior is such that, the worst day in a person's life may be being diagnosed with HIV.
Sure.
The
Sure.
second worst day is when they say, oh, you have to go on treatment. Then they feel like they're AIDS, they're really serious.
Yeah, it's a big step.
When in fact,
Yeah.
they have to get this new psychological curve figured out, because it really isn't about any of that. It's about being healthier.
I think that's right.
Yeah,
Absolutely.
and so just being treated doesn't mean you're worse off. It means you're going to be better off.
Absolutely.
It's like it's a reverse.
And I think the other thing that's really tough is that when you're starting treatment asymptomatic and well, having HIV is a little bit abstract, right? It's different from going to a doctor with KS, going to a doctor with PCP, and they say, listen, you've got this life-threatening illness that we can help you with it. Then, people then were grabbing at a lifesaver, right? And they were really holding on to it. Now it becomes a little bit more like diabetes or high blood pressure, in the sense that the problems are not immediately apparent to the person. They may be many years away. And you're right, the step of starting drugs, getting through whatever the side effects of starting a new drug are, good as the drugs are, those steps seem bigger, I think, these
I think
days,
it's
and I
also
think we need to work on that.
Well, I think it's a stigma also with the patient and their friends. Because
Sure.
I was completely unaware of the stigma around the big C. And people would say, oh, I didn't know they died of cancer. I didn't know they had cancer. They didn't want them to know.
Yeah, absolutely.
Because they didn't want
Yeah.
people to respond to them differently.
Yeah.
So we really have to get over that.
Yeah, I
that
think that's
stigma
right.
stuff is so harmful, it's so
Yeah.
damaging, so debilitating. And just live your life the best you can. Figure out
Absolutely.
what it is you have to do, and don't worry about it. If you don't want to tell somebody you're dealing with a challenging disease, don't. But it's not a problem. Most people will accept you the same
Absolutely.
as you are anyway.
Absolutely, and I think you're
Yeah.
right, certainly you don't have to go back very far to a point where people were so afraid of cancer that they would wait until it was so advanced that you maybe couldn't help them to come in and get a diagnosis.
Right. So
Yeah.
the message today is really get checked out. If
Absolutely.
if there's a sense that
Absolutely.
there's something wrong.
Absolutely, I would agree. Absolutely.
Well, I'm so pleased that you could be here today. It's just exciting, the stuff you brought to us. As you said, it's cancer is exciting. It's not great to have cancer, but it's good to know about it so you can do something about
I
it.
think that's absolutely right. Thank you so much for having me. It's been a
Well,
pleasure.
thank you very much, Mark. Appreciate
Thanks,
it.
Fred.
Yeah.